Today, the speech is going to be the role of bile acid in fat liver. The speaker is a world-known expert in pediatric GI and liver diseases, and is working in Children's Hospital in Los Angeles and also at USC in Los Angeles. So, Rohit, thank you again. The virtual podium is yours. Go ahead. Thank you very much.
Thank you so much, Professor Treveli. This is an amazing opportunity.
My name is Claudio, please.
Claudio, amazing opportunity to exchange notes here. So please do feel free to interrupt me throughout the process. I thought about what to focus on today, and I have decided to focus more on the journey that I've had along the way, the last almost I would say 15 plus years, trying to understand the intersection of bile acids and fatty liver disease. I came into Randy Seeley's lab in 2007, thinking that I will study just NASH in models of obesity and bariatric surgery. I had no clue that I would discover the world of bile acids. So let me walk you through that journey. I hope it'll be fun for you as well. Let me know if you can see my screen.
Yes, clear.
Perfect. So as I was introduced by Claudio, I work at Children's Hospital Los Angeles and am a professor at University of Southern California in Pediatrics. And of course, we've talked about our topic. I do want to mention some companies that I'm currently working with, both in research and consultancy, and leave that up for 10 seconds. I will be discussing some drug targets that are part of the portfolio of some of these companies. However, I will not go into any trademark names. So outline if I talk, again, pediatric GI, why is he interested in fatty liver disease? First of all, used to be the question people asked me. So I'll have a brief introduction of why this intersection is important for children. Of course, in Italy, you've had one of the world's most prominent experts, may he rest in peace, work on this disease, so it should not be a very uncommon question today. But back in 2005, 2006, when I started working in this area, it was a very common question. And then, of course, what's bile got to do with it? I'm in Hollywood, I have to bring out some kind of relationship to Tina Turner or somebody from Hollywood. So it's an interesting phenomenon which came to light. And of course, why everybody's interested today in novel drug targets for NASH coming along the bile acid pathway. So let's talk about fatty liver and why children get it. Of course, we all know where we started. This is one of my most favorite pictures I steal from Randy's deck, where to me, the more interesting part, psychologically speaking, in this snapshot is, yes, there's a huge burger this person is digging into, but look at this person. She has her own large burger, but her eyes are on his burger. That tells me more about the human psychology than anything else. So let's try to focus away from the other person, what they have, and focus on ourselves. Anyways, so ourselves today, pediatrics, this was a recent report from Jeff Schumer's group in San Diego a few years ago, and they showed that the same cohort, this is a controlled cohort, almost like Sweden has very nice data, longitudinal. Kaiser Permanente here in Southern California is a closed healthcare system, and they have some longitudinal data. And they saw increasing the incidence rate from 36 in 2009 of fatty liver disease in children using the same, of course, diagnostic algorithm to 58.2 per 100,000. So almost a doubling of the incidence of fatty liver disease in children. So that's understood. Okay, that's great. You have excess fat in your liver in children who are growing age. But what about NASH? Is there steatohepatitis in children? Was a question that I have had to answer quite a bit. So yes, there is data going back all the way to 2006 from autopsy studies where the whole spectrum, the whole umbrella of fatty liver, steatohepatitis, and cirrhosis exists in these percentages in children. So let's talk about one child, not a large data set. I saw this child back in 2009 in my clinic. He was a 10 years old boy at that time. had elevated liver enzymes, not horrendously elevated, 161, 59, was on some medications and had a normal A1C. 2 years later, he had been not available for follow-up between 10 and 12 years of age. His enzymes were still high. His A1C was still normal. However, let me show you liver biopsies from 2009 and 2011. So this is his 2009 liver biopsy when he was 10. You can see pan-lobular steatus. All the liver cells are filled with vacuolated neutral lipid. And there seems to be in this trichrome stain some beginnings of collagen deposition. So we called it, the pathologist called it about stage 1C from stage 1 through 4, fibrosis, 4 being cirrhosis. In 2011, when he came back at 12 years of age, he had already received all the way up to stage 3 labeling by the pathologists. And you can see that the steatosis actually is dropping off a little bit. And this is something that we see quite a bit. As steatohepatitis progresses, you have increased inflammation, fibrosis, but you have dropout of steatosis in these almost cirrhotic nodules that are forming. And is that it? Well, there was this child who was 13 years old that we reported on an incidental finding in an abdominal scan that was done, CT scan in the emergency room for abdominal pain, rule out appendicitis. They found this lesion that was in the smack in the middle of the liver. It was highlighted by a vascular supply phase as well. And in staining was found to be beta-catenin activated. So it wasn't HCC, but we're starting to see, and all the other testing for chronic liver disease turned out to be negative. And when this child lost weight, she reversed this lesion as well. So interesting that in pediatric NASH at 13 years of age, we're already seeing beta-catenin activation. And of course, it's true when the lay press starts talking about it. And we know from Naeem Al-Khouri's work that fatty liver disease is the fastest growing reason for transplants in young adults in their 20s and 30s in the US today. So what are we going to do about this? If we agree that pediatric fatty liver disease is a problem that a pediatric GI should be focused on and spend his career on, then what can we do about it? So of course, we have weight management clinics everywhere in the world. We're trying to damp down on this obesity pandemic, even before the COVID pandemic hit our shores. And we have a weight management clinic at CHLA as well. However, there's another wave that's going on, which is of surgical interventions. And this is what drew me to Randy's lab back in 2007, that he was very facile in bariatric surgery models, Roux-en-Y gastric bypass, sleeve gastrectomy in rats. And we wanted to understand, what do those models show in terms of NASH? How does that NASH improve or reverse in those models? So, as I said, lifestyle is important. You can have some amount of improvement in weight loss, about maybe 5 or 6%. But unfortunately, a lot of us have tried this for ourselves even, and there's a tick mark sign. You start to regain body weight. Drug therapy can help somewhat. Now we have even more sophisticated ways like GLP-1 agonists that are on the market that are very strong in producing weight loss, much more than just lifestyle alone. However, surgical therapy produces a weight loss which is way above beyond these two, such that you have to change the y-axis when you map it out. You get 30 to 40% drop in excess body weight. So even adolescents in the US are getting this surgery now. So it behooved us to start to understand this and start to decipher what happens in bariatric surgery in terms of pathophysiology. This is a large body of work that has been led by the National Institutes of Health U01 funded study by Tom Inge and his group. And this one came out in the New England Journal about a decade ago now, where you can see he was following both sleeve gastrectomy and gastric bypass here in the blue line, again, mimicking about a 30 to 35% excess body weight loss from baseline over a 3-year period in adolescents who had gastric bypass or sleeve gastrectomy surgery. So if I can say so to summarize this first section, why am I here? Because a pediatrician is interested because obesity is a problem in children. NASH definitely exists in children. so much so that young adults are having gastric bypass, sleeve gastrectomy, or even liver transplants in their 30s. There has to be a better way to deal with this problem. That's where bile comes in. So when I talked to Randy early on about how bariatric surgery works, he says, let's not think about what everybody has been thinking about, which they think is restrictive surgeries or malabsorptive surgeries. Are there metabolic pathways and processes that can maybe increase energy expenditure or can impact signaling for early satiety? What is going on behind the scenes in these surgeries? This is a more recent report, not from back in the 2000s, early days, from a group that looked at how NASH is changing plasma bile acid levels in preclinical models. And one of the things that they've, in clinical models, and what they've seen is that insulin resistance, so much more tied through to the overall milieu of diabesity, is NASH and its increase in bile acids. So bile acids seem to be increased in individuals who have NASH and insulin resistance. And what we had seen back in other people had seen, this is a report from Mary Elizabeth Patty. They had an adult cohort and they had looked at individuals who had gastric bypass matched to individuals who were overweight or morbidly obese. And what they saw was that total plasma bile acids were elevated in individuals who had gastric bypass. And it actually synced back, interestingly enough, now the wave of GLP-1 agonists that we're seeing to log corrected values of plasma GLP-1. So bile acids seem to be linked to bariatric surgery and GLP-1. There was another paper from a Japanese group that looked at, quote unquote, again, the restrictive and malabsorptive components of surgery. So they said restrictive is sleeve gastrectomy and other similar procedures, and malabsorptive is Roux-en-Y gastric bypass. But the same story that Mary Elizabeth Patty saw in Boston was that when you have a drop in body mass index after these surgeries, you have an increase in bile acids circulating in your plasma. So what is the significance of these observations in humans of increase in plasma bile acids after bariatric surgery is what we wanted to understand. So our first significant contribution was in collaboration with Sam Klein's group in Washington University, St. Louis, and where he had a cohort of matched weight loss after gastric bypass, Roux-en-Y gastric bypass, or the lap band. Does anybody remember the lap band? It came and went like a fleeting summer. And here, Roux-en-Y gastric bypass specifically, we found had elevated plasma bile acids, similar to the work that was published by Mary Elizabeth Patty and the Japanese group, but not in the gastric band group. So Al Roker is a big TV personality in the US. He had the Roux-en-Y gastric bypass and his bile acids are probably high. Sleeve gastrectomy produces weight loss. And again, I'm in Hollywood, I have to showcase some celebrities, but not gastric banding. I could not find a individual in the Hollywood genre who had gastric banding, because nobody wants to talk about a failed procedure maybe, but they do not have elevated bile acids. But I found a politician. This is our governor from New Jersey before, Democratic politician, and he had gastric band, but it didn't work. So can we study this bile acid phenomenon in bariatric surgery became the question. So we moved back to the lab. When we move back to the lab, we have this basic construct of a enterohepatic circulation. Of course, dietary cholesterol, when you circulate back into the liver, becomes the substrate for formulation of bile acids. Both cholesterol and bile acids come into the duodenum, get reabsorbed. Majority of bile acids that are not used get reabsorbed through the ileum, through ASBT and so forth, back into the portal circulation and back into the liver. So the first experiment we did was we transposed in rats the ileum. We moved this blue section of distal small intestine, the ileum, to a proximal portion of closer to the duodenum, just after the duodenum. And why is this area important is because this is where ASBT lives, the apical sodium bile acid transport mechanism. And we are therefore short-circuiting in this set of experiments the recirculation, enterohepatic recirculation of bile acids. And what did we find? So in sham-operated rats in blue here, initially the surgery has some insult, they lose weight, but they gain weight back on a high-fat diet very quickly. However, these ileum transposed rats, they lose weight and they maintain the weight loss for much longer, almost 3 weeks, before they slowly start to regain. And we had a cohort where we matched this weight loss by restricting the food intake, matching it to the ileal transposed rats in sham-operated rats shown here in green. So you can see that the weight loss was matched very closely by dietary restriction of food available to the animals depicted here in green, who had no real ileal transposition surgery, just a sham surgery, but we wanted to see what happens to physiology. So in these three groups, the sham pair fed, and the ileal transposed, you can see clearly the only group that had high serum bile acids was the ileal transposed group. So weight loss had nothing to do, neither in the lab band from Sam Klein's cohort or in our pair fed animals. Weight loss had nothing to do with the changes in bile acids. So we reversed this phenomenon. We said, instead of moving the ileum, how about we move the bile? So we cannulated the bile duct in rats, who of course have no gallbladder, into the jejunum. And when we do this bile diversion surgery, again, we produce weight loss, but only in the bile diverted group do we see the increase in serum bile acids, not in the sham operated. So when we put these preliminary studies that we had done modulating bile acid flow in ileal transposition or bile diversion, it produces metabolic benefits of bariatric surgery. I didn't go over this data, but believe me, of course, it's all published. Loss of fat mass, improvement in insulin sensitivity, and of course, increased serum bile acid levels. So what about established bariatric procedures? So we started to do sleeve gastrectomy in mice back in the early 2010s. And of course, this is not anything new. We take away 90% of the stomach. This is a mouse with a staple line about 1 centimeter across. And when we do this, again, we produce in the sleeve gastrectomy mice good weight loss, which is maintained for quite despite access to high-fat diet for quite a few weeks, whereas we have a high-fat diet provided to surgery naive in green, or sham-operated animals in blue and black, and sham pair-fed animals that end up being the same body weight at the end of 2 months to the sleeve gastrectomy. So the important thing is here, at the end of 2 months, we have two groups, the sleeve gastrectomy and pair-fed, again, body weight matched, but I will show you metabolically and physiologically bile acid specifically different. So back to the liver. In a sham-operated animal, of course, there's a lot of steatosis in the liver, and in sleeve gastrectomy, there is none, which would be expected. Triglycerides are down in sleeve gastrectomy in the liver, which again would be expected. However, fasting bile acids are up only, again, in the sleeve gastrectomy mice, not in the sham or even in the sham pair-fed, both in fasting and postprandial. We dived into the bile composition, and there was significant changes here. I'll not go into the details, but suffice it to say that taurine conjugated, glycine conjugated bile acids and 12-alpha hydroxylated bile acids were different. So here's tauro-ursodeoxycholic acid being significantly higher in the sleeve gastrectomy, and also cholic acid. So not only were they elevated, but just like what was seen post-bariatric surgery in humans, we saw a correlation to body weight loss and bile acid concentrations in our mice that had sleeve gastrectomy. This is 14 days past surgery. Serum bile acid concentration was correlating with weight loss. And this was maintained at 60 days as well. So why and how are these bile acids elevated after sleeve gastrectomy? One of the things we found is that in mice that had sleeve gastrectomy, there was an increase in surface area in the ileum compared to what was seen in sham pair-fed mice. So the villi were growing longer and had a adaptive response to the bile acid milieu, so to speak. And this is staining highlighting in green in immunofluorescence the well-known ASBT transporter mechanism. Again, in sham pair-fed mice, compared to sleeve gastrectomy. The sleeve gastrectomy mice not only had longer villi, but they had much more per meter square ASBT positive staining. We did another fun experiment together with Ken Sechel's lab, of course, who is responsible for all the bile acid composition analysis, his lab. And what we did was we took deuterium-labeled taurocolic acid and injected it into mice that were either sham operated or sleeve gastrectomy operated in their carotids. And if you see the sham operated animal, when you inject taurocolic acid, which is deuterium-labeled so we can follow it over time, there was not much increase in circulating, in the systemic circulation, taurocolic acid in the sham operated. But in the sleeve gastrectomy, within 20 minutes, we saw the deuterium label show up. So the suspicion that we had of short circuiting, just like we did in ileal transposition or bile diversion, I hypothesize it exists even in sleeve gastrectomy because you have a much more robust expression of ASBT per meter squared, and you have increased availability of surface area to reabsorb this short and produce the short circuiting of bile acid circulation. And of course, in the liver itself, because of different physiology, which we'll go over later, it is down. This is not unpublished. This came out in American Journal of Physiology now 3 years ago. Apologies, I haven't updated this slide. So if bile acids are so important, why not just give these bile acids and produce effects? Well, people have done it. Dr. Otamis Ligil's group actually tried way back in 2006 in a paper in Science, and they showed that if you give tauroursodeoxycholic acid, again, something we had found was high in our mice that had sleeve gastrectomy, and produce a reduction in ER stress and improvement in hepatic insulin sensitivity. Sam Klein's group themselves back in 2010 had also shown improvement in hepatic insulin sensitivity when TUDCA was given to obese men and women. So interesting that people had thought of this pathway already. However, we wanted to prove it in rats in a more mechanistic form. So we actually gave TUDCA exogenously through catheters inserted into the distal jejunum of a rat with a mini pump placed on their backs. And it also produced weight loss. Very nice, if you can see 1 and 2 milligrams per kilogram per day. The problem is, everybody knows if you get too much bile acids, you will produce diarrhea. Also, more recently, Leclerc's group showed that in OB mice, when you have significant NASH, there is a total bile acid concentration decrease in portal circulation, while there's an increase in the systemic circulation. So what is going on in NASH with bile acids being so different, as seen here both in human and in preclinical data? So we started to look into more the pathways. Yes, total overall bile acids are changing, but what is the signaling behind all this? So I'll highlight a few different parts of the signaling cascade here, which we have been talking about, alluding to. We talked about ASBT or ISBT, where bile acids in the ileum are taken up, but they will trigger the next step of pathways, which is farnesoid X receptor, FGF15 in mice and 19 in humans, which then, of course, through the portal circulation, hit back on mechanisms within the liver of lipogenesis and bile acid synthesis through, again, similar receptors, FGFR4 and farnesoid X receptor. So the first thing that our group looked at was the farnesoid X receptor. It happened to be in both liver and in intestine. So how about if we worked with mice that lack the farnesoid X receptor? So this is a paper that was led by Karen Ryan, again from Randy Seeley's group, and we were privileged to be part of, where they used FXR whole body knockout mice, and this is back in 2014. And these are colors chosen by Karen. So the lavender group on the right, you can see is knockout sham versus knockout VSG in the open squares. And what you see here is that the weight loss that initially was seen in the VSG, of course, I've shown you similar curves already from our data, there is regain, but there's a delayed regain. For about first 4 weeks, you're seeing a decreased amount of weight regain despite access to high-fat diet, compared to the sleeve gastrectomy animals, which maintain the weight loss for a longer period of time as we have followed them up to 14 weeks. So what we're seeing is that these knockout animals who have sleeve gastrectomy have less robust response to sleeve gastrectomy. There is weight regain much faster than compared to what happens in a wild type animal. And behind the scenes, what's happening in food intake is even more interesting. In the wild type WSG, you will have decreased food intake for at least the first 4 weeks after sleeve gastrectomy. However, not so in the knockouts. The knockouts start to eat normal within the first fortnight. Within 2 weeks, they're back to normal. Actually, we had a time point at 4 weeks where they ate more. The knockout VSG animals ate more than the sham operated controls in the knockout mice. Very intriguing that you have lost 90% of your stomach volume and you can eat more than your sham operated counterparts. And this goes back to the small kind of more frequent meals paradigm. So what is that? Is that the answer? Is FXR the controlling mechanism for food intake in obese animals? So this has led to a deluge of focus on therapeutic approaches on this pathway. We started with a multi-center trial with an FXR ligand, which happens to be a modified bile acid, obeticholic acid, which came out of Italy. And this is an adult study, of course. And what we saw is that, yes, it improved histological features of NASH. This was done by the NASH Clinical Research Network, again, an NIH-funded study. However, when you mess with bile acid mechanisms, there are things that we talked about before, such as the substrate, which produces bile acids, cholesterol. So there was decreased HDL in these patients and increased LDL. So a lot of non or unintended consequences when this is this mechanism, this pathway is modulated. So FXR agonist per se did not seem to be the answer. So in the last few minutes of my talk, and then we hopefully will have time for discussion and questions, is what is the focus today of this pathway? Where are people focusing on today? And it's a laundry list. You can see that there are many NASH therapeutic targets that are being talked about. But I will focus, of course, only on today's topic, which is FXR pathway related, bile acid signaling related. And you can see these are clearly obeticholic acid. I just showed you the data as an FXR agonist, but there's ASBT inhibitors that are being talked about. And of course, FGF15-19, specifically 19 in humans and 21 is also being modulated. So back to our cartoon, we continue to follow the pathway. So let's talk about FGF15 next. So we had a paper where we really dived deep into FGF15 knockout mice and had a paradigm for doing sleeve gastrectomy. And in those mice, in the FGF15 knockouts, again, we saw that the bile acid changes were persistent, were robust, that in knockout FGF15 knockout mice, there is an increase in serum bile acids. However, the one thing that we saw that was different at the liver level phenotypically was that esterified cholesterol, the not so good cholesterol. I mean, if you have excess cholesterol ester storage, you can get Wolman's disease or lysosomal acid lipase driven deficiency, cholesterol ester storage disease. And here we have increased amount of cholesterol esters being stored in FGF15 knockout mice that have had a sleeve gastrectomy. And what is the consequence of this increased esterified cholesterol? You start to see more inflammatory infiltrates in FGF15 knockouts. You start to see a higher inflammatory score when you score them, and no improvement in liver enzymes, which you of course see with wild types when you do sleeve gastrectomy. So the improvement in liver disease is not there anymore when you don't have FGF15-19 active in a sleeve gastrectomy model. In human studies, this is of course FGF19 analog F-ruxolitinib. They also initially saw, if you look at change in MR-PDFF, which is an MRI proton density fat fraction measure of hepatic fat fraction, they gave this FGF19 analog and saw an improvement depending on the dose, what they were giving of hepatic fat fraction. They also saw in the same doses an improvement from baseline in ALT in these colored lines compared to the black, which is in placebo. But when they went to that was a small cohort. When they went to a larger cohort with aldaferin, I'm sorry, this is the initial report for aldaferin, which is about 70 individuals. There was again an improvement in fat content, fat fraction with aldaferin, and an improvement with no worsening of NASH in this NAS stage 2 to 3 fibrosis or above. So if you look at overall fibrosis improvement and NASH resolution, there seemed to be a signal here. So this study was then tried to be replicated with a larger cohort of more than 700 individuals, but unfortunately here did not produce a significant response on fibrosis improvement. So when they started with the 70 cohort, there was signal in that gastroenterology paper, but this paper that came out last year in the Lancet with the same drug did not reproduce in a larger cohort of 700, 800 individuals a significant response. So beyond FGF15-19, there has been a lot of talk of FGF21 recently as two sides of the same coin. Are we manipulating the same pathways differentially with these fibroblast growth factors 19 and 21? We actually looked at 21 back in about a decade ago. And what we had seen was, again, in adolescents who had bariatric surgery, there was a correlation between weight loss and FGF21, as you can see here, levels post-surgery, especially out the way into 30 days, it was robustly maintained. However, the trials in humans with FGF21 analogs have been kind of hit or miss. This is Falcon 1, where pegbelfermin versus placebo showed some ALT improvements and NASH fibrosis improvements. However, they had to lean on non-invasive tests along with the liver biopsy because the primary endpoint, which was improvement on liver biopsy, was not robustly met. There have been further studies that came out now using pegozafermin in phase 1B and 2A, which is maybe a little bit more preliminary compared to the previous study I showed, the Falcon 1 trial, that is showing interest in this area, but no definitive answer yet, whether FGF21 analogs, whether they're long-acting or short-acting, are going to be the answer. So back to the pathway, we've looked at FGF15, we've looked at FGF19, of course in human, the same thing in 21, and ASBT has still been of interest. So let's look at what has been come out on ASBT. So Saul Karpin's group from Emory actually published back in 2016 in a preclinical model how when they added ASBT inhibitors, you can get decrease in cholesterol esters. See, interestingly enough, in this hash bar, this is their drug with a high-fat diet on mice, and there's a decrease in NAS score, but also an improvement in cholesterol ester levels. So now people have tried to think, okay, if a single target is not working, like in AIDS, we use, of course, in heart therapy combination and many other diseases, hepatitis B, should we think about combination therapy in NASH as well? So one of the trials that has been recently in preclinical models shown some positive energy is combining this ASBT inhibitor with FGF15-19 treatments. And here they saw decreases in bile acid pool in this paper in CMGH and improvement in hepatic bile acid burden. So not only are we improving obesity, but also NASH and fibrosis is what was shown when you dual target kind of ASBT and FGF15-19. This is their data in terms of histology, and you can see in serious red that it'll highlight this is the chow animal, and this is the animal where both targets were hit together. So almost back to how chow looks like. It's very encouraging, but again, this is early and preclinical. So Unfortunately, this diagram that Ken and I put together back in 2015 still holds true. There is a lot of targets in the bile acid pathways. We have still yet to find the golden key that unlocks, without significant side effects, a resolution to our problem, which is NASH. So the work is still out there to be done, and more questions than answers, but definitely it has been a fun journey to get to this point. And so I'll summarize by saying we clearly understand that bariatric surgery increases serum bile acid levels and improves NASH. Those things were established quite robustly by multiple groups, including ours. Bile acid triggered pathways seem to be important to the hepatic benefits post-sleeve gastrectomy, which is the most prominently used bariatric surgery today in humans. Murine data seems to think that bile acid signaling is more important than using bile acids alone. So there's this uncoupling that I'd like to have you walk away from this talk. If nothing else, you remember that it's not the bile acids alone, but what they do in terms of the signaling. And lastly, there may be more along these lines that needs to be discovered, but there may be a plus minus here. How do we modulate these different mechanisms within the bile acid signaling pathway, either together or differently, to find the golden key to NASH therapy? Thank you so much for your attention. And thank you to all my mentors. Here's Randy's group at the top, Ken's group on the right, and our small group that we've now transitioned to LA. Thank you so much.
Well, thank you very much. I mean, it was very impressive.